So this is the first test, Cozen's test, a test for lateral epicondylitis. What I'll have the patient do is rest their elbow on the table, flex to about 30 degrees, and then make sure the forearm's pronated. We'll have them extend the wrist and then radially deviate it. And then I'll push them, holding on to their second and third finger, I'll push them down into wrist flexion and ulnar deviation, palpating the lateral epicondyle and looking for reproduction of symptoms of pain along the ECRB. Alright, next is the Mills test. This is another test for lateral epicondylitis. What we'll do is we'll have the patient relax, and I'll pull their elbow, palpating the lateral epicondyle, I'll pull their elbow into extension, flexion of the wrist, and then ulnar deviation. Hold this position and feel for any symptoms or pain along the lateral side of their forearm. This is the third digit extension test. This is another test for lateral epicondylitis. It's basically an MMT of the extensor digitorum. What I'll have the patient do, they can rest their arm on the table and then they'll extend their third digit. Let's go ahead and do that. And then I'm going to push them down into metacarpal flexion, and they're going to try to resist this for me. Paying attention to the patient, seeing if they have any symptoms or pain, again, around the lateral epicondyle. This is the golfer's elbow test. This is a test for medial epicondylitis. Passive stretching test. We'll have the patient relax in flexion, and then I'll move their elbow into extension, extend the wrist, and then radially deviate as well at the wrist. Hold this position, palpating the medial epicondyle and listening for any symptoms of pain. This is the Valgus stress test. This is a special test for the MCL ligament of the elbow. What I'll have the patient do is extend their elbow, and then I'll provide one hand proximal to the elbow joint, and then the other can kind of stabilize at the distal forearm or the wrist, and then I'll provide a lateral to medial force for my left hand here, pushing them in the valgus, palpating also the medial epicondyle and listening for any symptoms of pain. And then also you can go ahead and flex the elbow to about 20 to 30 degrees and keep doing this same test at different degrees of flexion. This is the moving valgus stress test. This takes a look at the MCL of the elbow. We'll start with the patient in 90 degrees of abduction and full arm flexion. Bring your wrist out this way a little bit. And then what I'll do, stabilizing the elbow and palpating the MCL or the medial epicondyle, I'm going to pull their elbow into full extension while also kind of pulling them into a valgus load. And preferably I would do this quickly. I'm not going to do it on her, but we'll go to about 30 degrees of flexion or so near full extension. Again, pulling out in a valgus direction to get some external rotation of the shoulder as well. This is the Varus stress test. This is a special test for the LCL complex of the elbow. Pretty much the opposite of the valgus stress test. Same positioning. I could also be on the other side of the patient. With my proximal arm here, or proximal hand, I'll be pulling them, or the force direction will be from medial to lateral, and this will create a varus force at the elbow. And then also you can do this at different angles of elbow flexion. Same thing, pulling them into a varus position at the elbow. Looking for pain at the lateral epicondyle or feeling for anything to move or anything. This is the posterolateral rotary stability test. This takes a look at the lateral collateral ligament of the elbow. The patient started lying supine on the bed. We'll bring their shoulder up into about 130 degrees of flexion, and the forearm will be supinated. And we'll start in full elbow extension, and then the force that I'll be applying is a supinatory force at the forearm, a valgus load at the elbow, and then an axial load as well. So, and we'll move them from full extension of the elbow into flexion. So it'll look something like this. and you're looking for laxity at the elbow, indicating weakness of the LCL. This is the upper limb tension test number 1. This biases the median nerve with the patient lying supine on preferably a treatment table. I'd bring their shoulder up into 110 degrees of abduction with some external rotation. Their forearm is supinated, and then their wrist and fingers will go into extension, stabilize at the scapula, and then I'm going to pull their elbow from flexion into extension, looking for pain along the distribution of the median nerve. If that's a negative test, I can go ahead and have the patient side bend their head to the opposite side to put a little more tension on the median nerve. This is upper limb tension test number 2. This also biases the median nerve. Instead, in this test, we'll have the patient abduct their shoulder to 10 degrees of flexion. 10 degrees of flexion. Forearm is still supinated. Wrist and fingers will still be extended. Come this way just a little bit. And again, we're going to stabilize at the scapula. Please excuse my improper body mechanics. And then I'm going to pull their wrist or their elbow into extension, and a little bit more of external rotation at the bottom just to bring out any symptoms. Again, if this is negative, I can have the patient side bend to the opposite side to put more tension on the nerve. For upper limb tension test number 3, this biases the radial nerve. It's essentially the same thing as upper limb tension test number 2, except I'll have them pronate the forearm at the end. So about 10 degrees of shoulder abduction, elbow flexion, forearm pronation, and then still extension of the wrist and fingers. I'll push them down into elbow extension, stabilizing the scapula, and then some ulnar deviation at the bottom here, looking for symptoms along the distribution of the radial nerve. So. This is upper limb tension test number 4. This biases the ulnar nerve with the patient lying supine on the table. I'll have their elbow start out in full extension, wrist and fingers extended, forearm will be pronated, I believe. And then stabilize the scapula. We'll pull them into elbow flexion, looking for symptoms along the ulnar nerve. You can also have them side bend their head to bring out any more symptoms if the first test was negative. Next is the elbow flexion test, and this takes a look at the ulnar nerve. So what I'll have the patient do is pronating the forearm, they'll bring their elbows up into full flexion, and then full extension of the wrist and fingers. And then they're going to hold this position for up to 3 minutes, and I'll ask them if they feel any nerve or damage or any damage along the distribution of the ulnar nerve. Next is the Tinel sign or the Tinel sign. I don't know how to pronounce it, but it's kind of like a funny bone test. It takes a look at the ulnar nerve. Just hold their elbow out in extension and then tap at the medial epicondyle, or it's proximal to the cubital tunnel. So it's basically tapping the ulnar nerve and trying to elicit those the same like funny bone feeling essentially. This is the Pronator Teres syndrome test. This assesses the median nerve. What I'll have the patient do, they'll start almost in the waiter's tip position, but they can keep the elbow and keep the wrist flexed. And then I'll pull them into full elbow extension while they maintain that position. And what I'm going to ask the patient to do, try to bring their forearm into pronation, and then I'm going to also resist that as I pull their elbow into extension. And we're going to look for reproduction of symptoms along the distribution of the median nerve. This is the Wartenburg's test. I'll have the patient lay their palm flat down on the table with their fingers extended. And then what I'll ask them to do is try to go into finger adduction and bring the fingers together. And then back out. A positive test would be that they can't bring their fifth digit or their pinky finger in with the rest of them. And this would show signs of weakness of the ulnar nerve. This is the pinch grip test. what I'll have the patient do is try to touch their index finger to their thumb, tip to tip. This is a negative test. A positive test would be pad to pad instead, and that would indicate weakness or some other symptoms of the anterior interosseous nerve.